Good morning or good afternoon. I'm Monica Pica with Sachs Healthcare Communications, and I'll be your technical producer for today's webinar. The title of today's webinar is Early Initiation NIV at Home Improves Survival of COPD Patients. Before I introduce our moderator, Lexi Caraway, and our speaker, Dr. Frazier, I'd like to review a few housekeeping details. Today's webinar is being recorded. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab, also located on the right-hand side of your screen. And if you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC, or Command R if you're using a Mac. Please make sure you are not behind a firewall, as this will prevent you from viewing the presentation. Our moderator is Lexi Caraway. Lexi Caraway is currently a senior patient trainer and a former manager of respiratory at Sarah Bush Lincoln Health Center in Mattoon, Illinois. Her department participated in the survey mentioned in the recent study, Prevalence of Burnout Among Respiratory Therapists Amidst the COVID-19 Pandemic. Lexi has published several abstracts at AARC Congress, including a study on thermographic imaging to detect and prevent pressure injuries. She has presented at several local and state respiratory care conferences. Welcome, Lexi.
Good morning. Thank you, Monica, for that very kind introduction. The title of today's webinar is Early Initiation NIV at Home Improves Survival of COPD Patients. This is a very timely topic during COPD Awareness Month. We are excited to have a true expert in the field of COPD, Dr. Frazier. Dr. Frazier worked for more than 30 years as a full-time practicing pulmonologist. Dr. Frazier has served in many different leadership roles during his career, including stints as chief of the medical staff and on the board of directors of 2 large medical practices, and as a director of regional health system. Dr. Frazier has conducted clinical research projects, including trials evaluating new treatment options for COPD. He was first author on 3 articles published in peer-reviewed journals in 2020, 21, and 2022, reporting the significant benefits seen in patients using HMV as therapy for COPD. The speaker has disclosed the following relationships. A link to obtain credit will be available at the end of the webinar. This program has been approved for 1 contact hour for continuing respiratory care education credited by American Association of Respiratory Care. Support for this educational activity has been provided by Philips. And now I will turn our presentation over to Dr. Frazier.
Thanks, Lexi, and again, thank you for the kind words and a very thorough introduction. Good afternoon, everybody. Bill Frazier, sitting in Jackson, Mississippi, where it's sunny and 38 degrees in this late fall day, and I hope where you are, things are going well. I'm a pulmonologist. I've been around a long time and in practice over 30 years. And over the last few years, I have transitioned to a corporate role. I'm the Chief Medical Officer of VieMed, which is a national provider of non-invasive ventilation. I really do appreciate your time being here today. Let's set a couple of terms. You'll see on the slide, early initiation of NIV at home improves survival of COPD patients. Today's topic, NIV at home, NIVH, and I'll use that all the time. All right. What are today's learning objectives? Well, We're going to describe which COPD-CRF patients benefit from HMV. So sometimes I'll say NIVH, and sometimes I'll say HMV. HMV is home mechanical ventilation. NIVH, obviously, non-invasive ventilation at home. The same lexicon that refer to the very same process. We're also going to discuss the optimal time to begin home mechanical ventilation once the diagnosis of COPD-CRF is made. And finally, we'll describe the clinical value reduction in mortality and hospitalizations, and also a reduction in healthcare spending associated with home mechanical ventilation use in patients with COPD with chronic respiratory failure. Let's face it, non-invasive ventilation in the COPD-CRF space has been somewhat controversial. I've been around long enough to watch this develop, and I have some insights as to what's driven some of this controversy. The first time any of us began thinking about using non-invasive ventilation, early 90s, mid 90s, when we had the introduction of the bi-level positive airway pressure devices used to treat complex sleep apnea. Then we got the ST devices, the timed cycle devices. And some of us in the field had the idea that maybe we could use these types of devices to support people with COPD and chronic respiratory failure. Frankly, it was a last gasp treatment, sort of done in a what do we have to lose way. We considered hope for the hopeless. We didn't have much to offer. Maybe this would work. And I think that sort of willy-nilly seat of the pants approach has led to some confusion and perhaps to some of the controversy that surrounded this topic. We've had a lot of different opinions. People wonder if it even works. Who are the right patients to put on non-invasive ventilation for COPD, CRF? Well, when? Do we put patients on in the middle of an exacerbation? Do we wait for clinical stability? What do we do with that? What's the best equipment? What's the best piece of durable medical equipment to really support ventilation in these folks? And basically, in 2022, we got to talk about cost. We know that non-invasive ventilation is cheap, and is there a value proposition? Have we shown that there's actual value in using this type of therapy in these folks? And also, I think relating to some of this controversy is that we've not had a lot of reliable outcomes data, and this lack of consensus to the literature has led to some of the confusion. Again, we began this back in the early mid-90s, and some of the early papers used these BPAP, time-cycled BPAP devices and reported outcomes. And frankly, they weren't all that good. They weren't all that impressive. Several papers showed not a lot going on. And finally, in 2013, a Cochrane review, a meta-analysis was published that said, forget about it. This sort of approach really doesn't seem to move the needle in large groups of patients. Sure, we can all point out to one person or a couple of people who did well, but when studying big groups of folks, we just don't see much benefit. Therefore, we ought to stop it. And then the world changed. Technology caught up. We got the introduction of, no kidding, real mechanical ventilators for home use, which started to really appear in the market around 2012, 2013. We had a few new studies show up. We had the two more or less seminal European RCTs, randomized controlled trials, Conlon paper in 14, Murphy's paper in 17, which suggested there may be some real clinical benefits to this. That added or led to new op-ed pieces, new practice guidelines, one published in 2019 by ATS, another meta-analysis published in JAMA in 2020, a technical expert panel report published in CHEST in 2021, and everybody sort of came up with contradictory conclusions. So the confusion sort of persisted. And in that situation, that milieu, we decided to look at things in a little different way. Those of us doing the work said, hey, let's do some real world studies. Real world studies have become a bit more popular, a bit more in vogue, if you will. A real world study uses large claims data sets to ask not what happens just to patients that we select for randomized trials, but what about in the real world? People that we really put on this device. Can we get any information, any insight into results looking at claims data? So we set up a set of studies to do just that. Study one, published almost 2 years ago, December 29th, 2020, in the journal Respiratory Medicine, entitled Non-Invasive Ventilation at Home, Improves Survival and Decreases Healthcare Utilization in Medicare Beneficiaries with Chronic Obstructive Pulmonary Disease with Chronic Respiratory Failure. A really pithy title, huh? But what we did in this study was look at the Medicare limited data set. The LDS is a random 5% extraction from the total Medicare claims data. Couldn't get the total data. You could only get the LDS 5% of the data. So we took a broad look, choosing 2012 to 2018. We did that because 2012 was when the real ventilators, the codes E0466 began to appear in the marketplace, and those we wanted to look after those were available. So we took 5% randomly of all the Medicare claims from those years. Everybody was diagnosed with COPD and chronic respiratory failure, had to have both diagnoses. And we looked at those who were treated with mechanical non-invasive home ventilation at home and those who weren't. They all had the same diagnosis. Some were treated, some weren't. Outcomes all cause mortality and all cause hospitalization risk following the diagnosis of CRF. And the statistical technique we used was a propensity score matching one-to-one nearest neighbor. I'm going to go into that a bit more. This resulted in what's called the treatment effect on the treated. So what do we do? Well, we found the 517 patients in that data set who had COPD, CRF, and who were on non-invasive ventilation. And we searched the 44,000 patients with COPD, CRF who weren't put on non-invasive ventilation and found the 511 that closely resembled the 517 that were treated. We did a propensity score matching. By the time we matched these patients, and you can see that in the figure, they were nearly identical. And we matched them on several different parameters. We matched them on things like gender, age, region of the country they lived in, how much money they spent on their health care in the prior year, their comorbid states, the Charlson Comorbidity Index. And we ended up with two groups that were darn near identical, a real apples to apples comparison. And the questions we asked, was there a difference in clinical outcomes, specifically mortality rates and hospitalization rates, in the group of patients who got non-invasive ventilation for COPD, CRF? And here's what we found. All-cause mortality reduced. There was a 50% reduction in mortality risk over the 7 years of this study from 2012 to 2018. 50% mortality. And look at the Cox hazard ratio graph. That shows up very early. These lines begin to diverge within just a few weeks of treatment. You see mortality rates start to drop. After a couple or 3 years, about 20 months actually, you notice that there is no continued decrease in mortality, but there's no change either. There's no cross. You never lose that initial benefit. The mortality lines don't cross, so that you get early benefit that is persistent over years and years and years. We then looked at the 1-year data. What happened to mortality rates in the first year after we began COPD, CRF patients on non-invasive ventilation at home? And here's what happened. The mortality rate in the control group, the untreated group, was 46%. And the mortality group in the non-invasive ventilation group of folks dropped to 28%. An 18% 1-year reduction in mortality, an absolute reduction. That's a relative risk reduction of 39%. There's something interesting about that number. And I think those of us who've been in the field a long time know this, but it's been published now several times. The very high mortality that occurs in a COPD patient when he's admitted with an exacerbation. Richard Lindenauer published this in 2017, reporting a 42% 1-year mortality for patients with respiratory failure admitted to a hospital with COPD. You can see our number is 46%, and it shows up in other places as well. The take-home point is when you go into the hospital with a COPD exacerbation that's severe, your mortality is very, very high. And it turns out that most of these patients in our studies were initially diagnosed with the combination COPD-CRF while hospitalized. And if you'll treat those patients with NIVH, you can see the remarkable reduction in mortality shown in this study. What about hospitalizations? Shows up again. There is a significant reduction in hospitalization risk. For the entirety of the study, the entire 7 years, hospitalization risk in the non-invasive ventilation group reduced 28%. Look at the graph. Here's what's interesting. Mortality reduction happens early, the first few weeks. But look, not so with hospitalization risk. The patient's hospitalization risk begins to show up later. Usually 90 to 180 days before you see an advantage for NIV in reducing hospitalizations. I theorize that what's going on is that the lives we save, the mortality reduction, often has to go back to the hospital. But that after 90 to 100 days of stabilization, that doesn't happen. This benefit, this 28% reduction in hospitalization rate, goes on for a while. You can see the 1 year numbers. 1 year after beginning non-invasive ventilation, there was an absolute risk reduction of 11% in hospitalization rates. 67% of the control group had to be readmitted versus 56% of the treated non-invasive ventilation group. And again, look what a remarkable readmission rate that is for COPD. Once you've been in the hospital, you've got about a 2/3 chance of going back if you're not treated with non-invasive ventilation. If you are treated, it drops 11%. Now, let's talk briefly about numbers needed to treat. I really, really like this clinical metric. You've seen it used more and more in studies. What that means is how many times do I have to do an intervention to get the result that I'm measuring? Number needed to treat. I only have to treat 5.5 patients with non-invasive ventilation to save a life over the first year. Number needed to treat 5.5. I only have to put 9 patients with COPD-CRF on non-invasive ventilation to avoid 1 hospitalization. Number needed to treat 9. Let me give you some context. What's the number needed to treat for statin therapy and high cholesterol to prevent a first heart attack? About 70. How many COVID-19 vaccinations do you have to give to prevent 1 case? According to the original Pfizer article, about 135. How many do you have to give to prevent 1 COVID death? About 2,000. In the new triple inhaler for COPD, to get back to the COPD world, how many triple inhaler LAMA inhaled corticosteroid patients do you have to treat to prevent a death with triple therapy? About 135. Listen, I'm completely pro triple inhaler. I'm completely pro COVID vaccine. My point is simply how powerful non-invasive ventilation is in reducing mortality and reducing hospitalizations, with number needed to treat 5.5, number needed to treat for hospitalizations 9. Remember, this is in a group with COPD and chronic respiratory failure. We were, frankly, mildly surprised, pleasantly, about what robust results we showed with non-invasive ventilation using this real-world data approach. So we sat around and said, okay, what's next? Well, let's look at a slightly different population of COPD Medicare patients, and let's use a completely different statistical technique. I explained in detail about the propensity score matching 1-to-1. Let's do it another way and see if we get the same answer. So that led to study number 2, which is non-invasive ventilation at home reduces mortality in COPD with CRF. Published September 21, 14 months ago in the American Journal of Managed Care. What was this study about? Again, the Medicare limited data set, the randomly selected 5% of the Medicare fee-for-service population. We chose the years 2012 to 2017, and that gave us a treatment group of 410 COPD-CRF patients who were started on non-invasive ventilation as therapy for COPD-CRF, and a control group of about 36,000 patients who never got NIVH. But we used a different matching technique to be sure that we had another apples to apples comparison, but done a different way. We used what's called inverse probability of treatment weighting, really the most up-to-date, the most accepted 2022 way to do matching groups in these retrospective objective large studies. And what you do is develop a propensity score matching system, and you make the patients who didn't get treatment look like the ones who did using the statistical analysis, and that's called the treatment effect on the untreated. So that's the approach we used for study 2. And what did study 2 show us? Mortality. We looked at mortality again. The overall mortality reduction for the 6-year study period in study 2 was 38%. Remember, in study 1 it was 50%. We also looked at the first year mortality decreases. 42% of the patients who had COPD-CRF died within 1 year of diagnosis. Remember, it was 46% in study 1. Richard Lindenauer showed 42% in his studies. That number keeps showing up over and over again, pointing out how sick these patients are. Once they've been admitted to the hospital or diagnosed, how high their 1-year mortality is. But mortality was reduced from 42% to 29% with NIVH. That's an absolute risk reduction of 13%. It was 18% in study 1, a relative risk reduction of 31%, and the number needed to treat of 8. Again, a very powerful number needed to treat. Look at the curve. You can see the same thing, that the effect on mortality shows up very early. The patients begin to show a reduction in mortality almost immediately, and it persists over the entirety of the 6-year trial. So, what about hospitalization risk? Mortality looked very similar to study 1 and study 2. And here's hospitalization risk. Hospitalization risk declined by 21% over the entirety of the 6-year hospitalization. That was 20, what was that? It was 38% in 28% in study 1. First year hospitalization rates decreased from 65% in the untreated group to 56% in the patients treated with non-invasive ventilation, very similar to what we saw in study 1. Absolute risk reduction of 8% for hospitalization. Number needed to treat to prevent a hospitalization of 12. Look at the curves. You see the same thing, the same signal, right? Very, not much separation in the hospitalization rates early. Just like before, you don't start to see the curves separate for several weeks, 90 to 180 days, 3 to 6 months. We're seeing the same thing. Mortality reduction happens early after beginning NIVH. Hospitalization reduction rates occur later, 3 to 6 months after therapy's begun. Summary slide. Non-invasive ventilation at home reduces mortality and hospitalization in patients with COPD with chronic respiratory failure. During the 6-year observation period, mortality reduced from 42% to 29%. That's the 1-year data. Hospitalizations reduced from 65 to 56%. That's the 1-year data. And the overall mortality reduction for the entire 6 years in the treated group, 38%. So we're done. Things are good. We've done 2 studies. We've done them in slightly different, or actually very different statistical techniques. And that led us to ask, what's next? And again, the world changed. We got notification that Medicare would now allow us to have access to 100% of the data. Remember, before all I had was a random 5%. Now Medicare said, no, look at everybody. You can look at every claim and see if that will make any difference in your outcome. We thought, well, we got to do it. Now that we can look at 100% of the data, let's do the study a third time and see what we get. And that led to study 3. Again, a nice short pithy title, huh? Early initiation of non-invasive ventilation at home improves survival and reduces healthcare costs in COPD patients with chronic hypercapnic respiratory failure. A retrospective cohort study. We published this at the end of June 2022, so 3 or 4 months ago it appeared in print. What did we do in this study? Well, again, We had the entirety of the Medicare data set. This gave us much bigger numbers, obviously. Instead of a 5% sample, we had 100% of the sample. And therefore, we chose to look at patients who were diagnosed with COPD and chronic respiratory failure, 1116 to 1120. Why do we choose 1116? Because of the ICD-10 coding, International Classification of Disease, version 10, that came into effect in October of 2015. So everybody from 16 on had this type of coding, and it's a much more granular approach to coding. You get much more information about each individual patient using the ICD-10 coding. That allowed us to ask more granular questions, such as not only our favorites, mortality and hospitalization risk, which became primary outcomes, but we were also able to ask the question about the phenotype of chronic respiratory failure. What do I mean? Well, in ICD-10 coding, not only do you get told, yes, they've got CRF, we now know what type of CRF. Is it hypercapnic, high PCO2? Is it hypoxic, only low oxygen without hypercapnia? Or is it neither, hypoxic or hypercapnic? So you get three phenotypes of chronic respiratory failure secondary to COPD. High PCO2, which usually had hypoxia as well, hypoxia only without hypercapnia, or neither hypoxic nor hypercapnia. So we could put the patients in those buckets and assess outcome, assess response to non-invasive ventilation based on that CRF phenotype. We were also able to look at the effective timing. I've told you we saw these signals in the first two studies that mortality reduction happens early and hospitalization reduction happens later. But we hadn't set the study up specifically to ask that question. So with that knowledge in mind, we designed this study to ask the question about how does timing of initiation NIVH affect outcome. We use the inverse probability of treatment weighting program again. That's again the most sophisticated, if you will, the most up-to-date way to do these matching techniques and to get equal and apples to apples comparison group. And look at the size of our cohorts. We had 500,000 patients in the study, 500,000 patients. Everybody from 16 to 20 with COPD, CRF in the Medicare fee-for-service world. There were 500,000 of those guys. The treatment group, those on NIVH, 6,707, which gave us approximately 493,000 controls. We matched those controls using the inverse probability statistical technique and ended up with very similar groups to compare, apples to apples. And what did we find? Busy slide, sorry, necessarily busy. Spend a moment on this with me. I divided this into the full sample, that's all types of CRF mixed together, versus the hypercapnics, versus the hypoxics, versus the neither hypoxic nor hypercapnic form of chronic respiratory failure. When I did that, oh look, the full sample shows benefit in mortality with a significant mortality reduction. When you look at the subgroups, it's very clear that only COPD, CRF patients who had elevated PCO2s benefited. And they benefited well. You can see 43% reductions in mortality, depending on the grouping, 36-30. So we're still seeing that very large mortality reduction in this group, but only in the hypercapnics. In fact, in the hypoxic group, there was a small increase in mortality, and there was no benefit in the neither hypercapnic nor hypoxic. All of the benefits seen when I looked at the sample as a whole was driven by the results from the hypercapnic patients. This study is the first to show that only hypercapnic patients with COPD, CRF benefit. Now that's been a theory. Other studies have been set up treating only hypercapnic patients, but it's the first time that's been shown that only hypercapnic COPD patients benefit. We also, look on the left-hand side, did a data cut by when you started your non-invasive ventilation. If you began treatment in the first 7 days following diagnosis, you had the most robust mortality benefit, 43% reduction. If you started within the first 2 weeks, that decreased to 36%. If you didn't get started for the first month after diagnosis, your mortality reduction was reduced to 30%. So the later you wait, the less your reduction in mortality occurred. So in this setting, we're the first to show that earlier is better than later. Now, I didn't say it's ever too late. It's not. You still get some benefits, but the most robust mortality benefit occurs beginning therapy within the first month following diagnosis of hypercapnic chronic respiratory failure secondary to COPD. Let's look at the hospitalization data because, again, this is interesting, at least to me. At the top, full sample, hypercapnic, hypoxic, and neither hypercapnic nor hypoxic CRF patients. And guess what? Only the hypercapnic patients had a reduction in hospitalization. You did not see benefit in the hypoxic group. You did not see benefit in the non-specified, the neither hypoxic nor hypercapnic group. Only PCO2 elevation, CRF, has a reduction in hospitalization when non-invasive ventilation is applied. So then we did the same thing, and the reduction was about 15%, and that's been stable. 28% study 1, 21% study 2, 15% study 3. So a very consistent, reproducible, statistically significant, clinically relevant reduction in hospitalization risk with NIVH. And we cut it by when you began NIVH. And guess what? It didn't matter. If you began within the first week, hospitalization risk reduced 15%. If you began within the first 2 weeks, 15% hospitalization. If you began within the first 30 days, 15% hospitalization. If you began within the first 60 days, hospitalization, 15% reduction. It's showing the same thing we thought we saw earlier. Mortality benefit happens very early with NIVH and hypercapnic respiratory failure. Hospitalization doesn't. That seems to occur later. So no matter when you start NIVH, you get the same hospitalization reduction effect. But you get a much more robust effect when you start in mortality reduction when you start NIVH early. Earlier is the better for mortality. It's never too late for hospitalization reduction. So for the first time, we said, let's look at cost. We're all worried about healthcare cost. Obviously, we should be. It's a hot button topic, and it should be. So this has never before been reported. We know that non-invasive ventilation at home is relatively expensive, and we needed to ask the question: is there a value proposition? What happens to Medicare cost in these patients who were treated? And what we showed was that, again, in the hypercapnic patients who had COPD CRF, if you began treatment early within the first week, you reduced all-cause yearly Medicare spend by about 12%. That's around $4,500. That's all-cause expense. That's not expense related to COPD treatment. That's every nickel these patients spend on their health care went down 12% if you put them on non-invasive ventilation early after diagnosis. And that includes now the cost of the non-invasive ventilation. Even accounting for the cost of putting them on ventilation, you still reduced cost by 12% if they were treated early. If you began treatment within the first 2 weeks, you drove the cost down by about 7% over the first year. That's about $3,500. If you began treatment after 2 weeks of diagnosis, there was no cost savings, but there was no increased cost. You save money if you get started in the first 2 weeks following COPD CRF diagnosis, but no matter when you start, you never increase cost. The cost of therapy of NIVH is offset by the other benefits so that it becomes cost neutral. Weeks 1 and 2 reduce cost. After week 2, cost neutral. No increase, no decrease. Clinical benefits accrue with no cost to the system. So is there a value proposition for non-invasive ventilation at home in a Medicare fee-for-service population with hypercapnic CRF? Yes. Reduce cost up to 12% with early initiation of therapy. Again, Review so that we can all remember. Cost savings analysis. In the first year after beginning NIVH, 0 to 7 days, $5,500. First 2 weeks, $3,400. If therapy is begun after 15 days, cost neutral. Neither increases nor decreases cost, and the cost of the NIVH is in these numbers. Mortality reduction, 43% begun in the first week, 31% begun in the next 2 weeks, and 16% if it's begun weeks 2 through 4. The earlier you start therapy for mortality reduction, the better off you are. Hospitalizations, the 15% reduction remains constant regardless of the timing of NIVH initiation. Let's switch topics a moment. Let's talk about the equipment because there is some controversy about what equipment, which type of device might be best to treat COPD with CRF. Optimal equipment for COPD, CRF, and there are really two choices, right? There's the real non-invasive ventilator, the HCPCS code, if you will, of E0466 versus the E0470s and E0471 coded devices, the BiPAP or the BPAP or the RADS device, which is Medicare jargon for BiPAP with a time cycled mode. What are the difference in these two devices? Well, the ventilator has a battery backup. BiPAP and time cycle don't. The ventilator has alarms. Of course, as we know, the BiPAPs don't. The ventilator has a much more powerful turbine. It blows harder. 180 liters per minute maximum flow. The BiPAP time cycled in devices only have about a 90 liter per minute maximum flow, so less than half. The maximum IPAP, the maximum inspired pressure for the vents, about 50 centimeters of water pressure. For the BiPAPs and time cycled, it's 20, some go to 25, but something less than half of the maximum IPAP of the ventilator. And frankly, the ventilators have been shown to reduce mortality in COPD, while the BiPAP and time cycled products have not been shown to do that. Additionally, the FDA has approved the E0466 ventilators as life-saving devices to be used to treat chronic respiratory failure. The BPAP and time cycle BPAP devices have not. They're approved to treat sleep apnea. So you've got different FDA approvals as well. So to put this in another way, speaking of the optimal equipment, when I looked at the data in study 3, that was 100% of the Medicare data, covering 6,700 patients on non-invasive ventilation. 92% of all the equipment prescribed was a ventilator, an E0466. 7% of the group was on a BPAP, and only 1% was on a time-cycled BPAP. 92% of providers who wrote a prescription for COPD CRF between 2016 and 2020 in a Medicare fee-for-service population chose an E0466 ventilator. 92%. To me, that defines a standard of care. What's the standard of care legally? It's what a minimally competent physician would do in like or similar circumstances. And 92% of the time, providers said, I'm going to go with a vent. That means something to me. To me, that establishes a standard of care. Listen, I tried to look at BiPAP RADS outcomes devices. That's BPAP, time cycle BPAP. Outcome results by analyzing the patients who are on that therapy. Couldn't do it. There just weren't enough data points to be able to make any statistically valid claim. So I wasn't able to show whether they worked or didn't work. There simply wasn't enough data to make any sort of discussion. It's also important to remember, as I said, that ventilators have now been shown in published data 3 times in these studies to reduce mortality. The RADS and BiPAP have not been shown specifically to reduce mortality. And in my opinion, since we know vents reduce mortality, I don't want to use a device that hasn't been shown to reduce mortality until it's been shown to do so. I've looked, as of right now, I'm unaware of any trials of anybody looking at a BPAP versus a true ventilator in the COPD CRF space to see if there's any influence on mortality. There might be one that started. I can't find it if it's up and running. So right now, I don't know of anybody asking that question, but I personally am going to use vents for this very sick, very high mortality group of patients until I know it's safe to use another device, because I know it's safe and effective to use the vents. Study has limitations. All studies do, and these three certainly do. These conclusions I've presented are based on retrospective claims data. You can't use retrospective claims data to establish causality. I can only use the word association. I can't say there's causal, only that these outcomes are associated with non-invasive ventilator use. You can't extrapolate to populations that I didn't study. I studied Medicare patients in the fee-for-service traditional world, and that's who we can use this data to explain outcomes on. As I've just mentioned, all the patients in our 3 studies were on ventilators, EO 466. Therefore, you can't take the results of an EO 466 and extrapolate it to patients using other devices like the BPAPs or the time cycled BPAPs. You just can't do that because I didn't ask the question with those devices. And finally, and this is important, I can't comment if there's a correlation between hours of use of the device and outcomes. Look, I think everybody with COPD, CRF that's hypercapnic on these devices should use it 6 or 8 or 10 hours a night every night. But I can't sit here and tell you if there is some magic number, some metric that says if they use it less than 4 hours, they won't benefit, or they've got to use it more than 2 hours and more than 70% of the nights to get benefit. I don't know that, because that data is not contained in the real world Medicare database set. I just don't know. There's no study to say that either. Nobody's published data that says there's a magic bright line beyond which you benefit and below which you don't. The data is just not available. So I can't comment on how long you ought to use your device before you get benefit. Nor can I comment on how hypercapnic you ought to be. My patients who benefited in this study were hypercapnic. That means their PCO2 was greater than 45. I don't know if you benefit more if your PCO2 is higher. Is 52 the magic number? Don't know. Is 50 the magic number? Don't know. Is 45 the magic number? Yeah. I know if you are hypercapnic at any level, you'll benefit, because that's what my study did. It included everybody who was hypercapnic. I don't know if the more hypercapnic you are, the more you benefit, because it's precise PCO2 simply not in the ICD-10 coding. There have been a few studies that have limited this treatment to patients with PCO2s of 50 or 52, and that's fine. I agree, it helps those patients. But those studies didn't ask the question, does it help patients with lower PCO2s? Because they didn't put them in the study. All I can tell you is if you're hypercapnic, you benefit. I can't tell you if there's a magic PCO2 number where you benefit more. Replicated results are valid results. You hear this all the time, right? Don't show me something once. Show it to me 3 times. Replicate your outcomes. We looked at 3 different populations of Medicare fee-for-service patients, all of whom had COPD, CRF. We used different statistical matching techniques, both propensity score matching and inverse probability of treatment weighting, and we kept getting the same result. We kept showing reductions in mortality, reductions in hospitalizations, no matter how we mixed and matched our study. We've replicated the results 3 times, replicated results, and applied validity. So let me wrap up. What have I learned in the 4 or 5 years that I've been doing these studies? What have I learned that I didn't know? Well, I know that in hypercapnic COPD, CRF, non-invasive home ventilation is associated with large reductions in mortality, hospitalizations, and healthcare costs. Mortality goes down somewhere around 35%. Hospitalizations go down somewhere around 20%. Healthcare costs, as treatments begun early, go down somewhere around 12%. I've learned that only hypercapnic patients benefit from COPD, CRF. If you're just hypoxic and not also hypercapnic, you need not apply. If you are neither hypoxic nor hypercapnic with CRF, you need not apply. There is no evidence that you're going to benefit from non-invasive ventilation unless you're hypercapnic. And there's some evidence you might even do worse on non-invasive ventilation. So hypercapnia remains a gold standard metric for introduction of NIVH and COPD-CRF. I've learned that the earlier a patient with hypercapnic COPD-CRF starts therapy, the better he does. The better his mortality reduction and the greater his cost reduction. Doesn't affect his hospitalization risk, but he is less likely to die if you get him started early. It's never too late to start. That's not what I said. I said you do better with a better reduction in mortality if you start early after the diagnosis. This debunks the idea that we should wait for people to become stable before we treat them. No. The people, as we've talked about, who come out of a hospital with an acute exacerbation of chronic respiratory failure are at a high risk, 40% or greater one-year mortality risk. And we can greatly impact that risk by starting non-invasive ventilation. And the earlier we do it, the better. There's no reason, in fact, it's wrong, in my opinion, to wait 2 to 4 weeks to achieve clinical stability. Once you identify these guys, my data says the earlier you act, the better they do. Lastly, in my opinion, the optimal equipment to deliver home ventilation in these hypercapnic COPD-CRFs is a ventilator, an EO466. For all the reasons I've discussed at length, I do not think BPAPs or RADs have the data behind them to show outcomes as good as the ventilator does. And until that data exists, I think we have to default to EO466 ventilators. All right, team. That is what I know. I'm now going to kick it back to Lexi, and she will answer we'll try to do a little Q&A, and Lexi will tell everyone how to get their CEs. Thanks much.
Thank you, Dr. Frazier, for that very informative presentation. I would like to now tell everyone how they can obtain their CEs. To obtain CE credits, go to www.saxtesting.com/BO, register at the site, complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. Support for this educational activity has been provided by Philips. An archive on-demand version will be available on betteroutcomes.org. The on-demand version will be accredited for nurses and respiratory therapists. Okay, now we have time for a few questions. Dr. Frazier, I have a question here from Daylin. So NIVH decreases or delays mortality, and after 90 days, it decreases hospitalization as well. Has it had an impact on quality of life, or has it improved quality of life? And how is this being objectively studied?
It's a good question. My studies did not do that, again, because we were doing claims data studies, and that's simply not available in the claims data. That's been looked at, and like everything else, when I started out with the controversial literature, it's shown up both ways. Some studies show QOLs are better, others show they aren't. Some show an increase in activity levels and a decrease in COPD symptoms. Some don't. Those studies are hard to judge because, frankly, they're not very well designed, and it's hard to know. So I can't answer definitively, although I think living longer is a pretty good quality of life improver.
Agreed. Thank you. I have another question here from Amy. So why are more hospitalists or RT departments more proactive in starting CRF or COPD patient and starting to work on the admission process and getting these things qualified for earlier in the admission? I think, the comment here is that this should be the first day, so DME arrangements can be completed prior to patient discharge. Any thoughts on that?
Yeah, I couldn't agree more. I think the case manager and the RT and the doc, obviously, really have to work together to say, look, here we've got a guy in the hospital with COPD, CRF. We know what's going to happen if he goes home. There's going to be a 20 to 25% 30-day readmission. There's going to be a 2/3 1-year readmission rate. There's going to be a 40 to 50% 1-year mortality rate. Let's get going early. I'm not going to say you're going to reduce length of stay, but you might if you can get these people home early. I don't have any data to prove that, and I'm not claiming that, but it makes common sense to me that if we'll get started on day one. So how do you pick that patient? Boy, it's easy. He's got COPD and he's got hypercapnic chronic respiratory failure. Those are the only two things he needs. And if he does, start DC planning immediately.
Very good. Thank you. I know this was a retrospective study of data you were able to collect, but how was compliance measured, or how did you consider a patient compliant or non-compliant during this? And what did you do about the non-compliance?
Nothing, because compliance is not part of the ICD-10 coding. I have no idea. What I know, and if you think about it, makes the data even more interesting. What I know are the patients that were prescribed non-invasive ventilation. I have no idea how much they used it. And despite that, there was still this robust improvement. So I bet, now I'm making this up, boy, I'm off the reservation. I'm betting the patients who used it more did better, but I don't have that data. And as I said earlier, there is no magic metric. There is no hard number that's evidence-based that says you ought to use it 2 hours or 4 hours or 6 hours or 8 hours. What I tell my patients, the more the merrier. Get on that thing and use it 6, 8, 10 hours a day, and that's where you're going to do the best. But I never tell patients, if you don't use it ever, I'm going to pick it up, because nobody knows. Maybe some patients use it when an exacerbation starts. I don't know. Maybe some patients use it just 2 hours a night, 7 nights a week, and that's enough. I don't know. And the point is, nobody knows, because there's no data addressing that issue.
Thank you. I have a question here from George. Have you seen any anecdotal information regarding physical activity in the hypercapnic patients that have used a ventilator?
I have. And these are from some older studies. And they showed, and again, it's not consistent. Some studies don't show much change. I have definitely seen studies that show an increase in activity, and that's something that we need to look at. That would be relatively simple to do with just simple Apple Watch measures of steps taken, that kind of thing. And we could really, that would not be hard to do, to see if we can correlate degree of disease severity, use of the machine, and increase in activity. That would be a really interesting study. Somebody needs to do that.
Thank you. Did you have any data on, this question comes from Julie, did you have any data on the type of interface or mask that was most commonly used in relation with these studies?
I don't. Again, not included in our retrospective claims data. What I tell patients about masks, it's just like Baskin Robbins, right? There are 31 flavors, and that's why they have chocolate, strawberry, and vanilla. Everybody's a little different. Everybody's face is a different shape. And y'all have seen the same thing I have. You have one guy who thinks a nasal mask is the best thing in the world. And another guy thinks that same mask was something that they used in the Inquisition back in the 1500s. He hates it so much. Man, what's the right mask? The mask he'll use.
Good point. Thank you for that. And then I have another question here. This is regarding IPPB therapy. And back in the early days of non-invasive ventilation, how did it differ from IPPB? And then also, so this question is coming from someone who says, in school, I was taught to be cautious using IPPB with late stage COPD or CRF failure because of getting the patient off the therapy was unlikely. Have you seen that, or have you noticed that at all?
I really haven't. There was this theory at some point that you might hyper expand these air retainers by giving them, just hadn't shown to ever be a real problem. You remember the real ventilators, not the BPAP rats, we're actually setting a tidal volume just like you do in the hospital. Because of the, what's called the VAP, the volume assured pressure support ventilation. It's just a mode of ventilation only available on these ventilators. You tell the machine how much volume to give, and the machine, within limits, decides how much pressure that requires. Um, Completely anecdotally to me, I think that's why the ventilators work better, because you can guarantee a tidal volume. Listen, that's what mechanical ventilation is guaranteeing a tidal volume, not guaranteeing a pressure, but a volume. And that pressure is going to have to change as those lung compliance metrics change. And that if that machine can't do that, if it can't say, aha, more pressure because today Bob's more bronchoconstricted or whatever, he's got more mask leak or whatever, it's that ability to change pressure to guarantee volume. I think that's the soul of mechanical ventilation. I think that's why the ventilators work better.
Okay, perfect. And then we have one more question here before we wrap up, but the last question is going to be, did you notice a difference between, or were you even able to capture this information with the data you received? Was there a difference between patients who used the ventilator while sleeping only, or also used it during the day as needed?
Just not available. Data is just not included in the data set that I reviewed. I have many patients who use their ventilators during the daytime. They'll often use them after exertion. I've even got a few who use them before exertion. And there's nothing wrong with doing that. I cannot speak from an evidence-based way as to whether or not that really makes a difference.
Perfect. Okay, thank you everyone for all your great questions this afternoon or this morning. And I'm going to now turn our presentation over to Monica for concluding remarks.
Thank you so much. And immediately upon conclusion of this webinar, you will be presented with an online survey. So please do keep your web browser open. We appreciate your feedback. And of course, as a reminder, nurses and respiratory therapists, to obtain your CE credits, visit www.sacstesting.com/BO and register at the site and complete the evaluation. Once again, thank you on behalf of our presenters, Sacks Healthcare Communications, and our sponsor, Philips. I hope you enjoy the rest of the day.